I'd like to welcome you all for this inaugural MedEClasses webinar on various aspects of thyroid physiology and assessment. And this is the part of our initiative to really reach out to people from across the country and in fact beyond the country to focus on disorders which can be difficult to ascertain, evaluate and manage. And rather than actually having a lot of on-site conferences, we are planning to have more webinars. And this is just the first initiative that we are taking now. We are going to really have it probably in a bi-weekly or twice a month at least on a basis, and we'll have focused webinars specifically designated for pediatricians, for pediatric endocrinologists, for trainees, and we'll go forward from that. This one is particularly important from every perspective because thyroid disorders are important for everybody, be it pediatricians, pediatric endocrinologists, those who are doing medicine, who are looking for pediatric aspects. So I think this is a very relevant part. The agenda for today basically is to start off with the introduction about thyroid disorders, the launch of the Growth Society MedEClasses thyroid course, followed by a brief word about thyroid physiology, followed by thyroid function assessment because these are one of the most commonly prescribed tests and often are associated with complicated results which cause confusion in evaluation and management. We'll then go forward to thyroid structure assessment, particularly focusing on thyroid scan, thyroid ultrasound, and how do we reach etiology. The overall flow of this webinar is basically to target predominantly the practical aspects and how we can use physiology and apply physiology in terms of evaluation and management. And finally, we'll see if we have time for Q&A. So this is going to be a busy webinar and we are going to have a lot of interesting cases and questions discussed down there. This is basically part of the MedEClasses program. Pediatric endocrinology, which become accessible for pediatric endocrinologists, pediatricians, and those who are interested in various aspects of pediatric endocrinology. Number of resources are available in the form of educational videos, which are available in our free sections, which cover key aspects of pathophysiology, assessment, and management. There are useful links which are available regarding the various societies which are there and the various guidelines which have been developed regarding different disorders. Our key unique part is the development of courses which we have developed, and these courses focus on different aspects of pediatric endocrinology. So we have got a comprehensive pediatric endocrinology course which is available as an online and an on-site option. And these courses provide a bundle of 6 courses in the form of growth, puberty, thyroid, calcium, glucose, and electrolyte. And each of these courses have got 6 modules individually. So today we are focusing mainly about thyroid physiology and assessment. So this thyroid module, which is in fact being launched today, encompasses 6 key aspects of pediatric endocrinology relevant from thyroid disorders, starting from thyroid physiology and assessment, including congenital and acquired hypothyroidism, thyrotoxicosis, solitary thyroid nodule, and goiter. Each of these modules actually starts with a pre-test in which one has to answer a few specific questions. So there are pre-test questions and post-test questions. And once these questions are answered, we would then move forward to the actual course. And once we start with this individual module, we have a collation of videos which cover different aspects of thyroid physiology assessment, as in this case, along with a number of sections which individually talk about the various aspects, including the introduction, the physiology, and each of them has got extensive and exhaustive text which is available in this perspective, which is complementing the video. These are followed by key aspects related to assessment, particular importance for clinical pointers, and the videos use a lot of animations for that. Today we'll be mainly discussing about the thyroid physiology and assessment, and that forms the basis, and we are going to use a lot of cases and clinical perspectives to highlight the various aspects of pediatric endocrinology related to thyroid disorders. Okay, so why is thyroid physiology and assessment important? Because thyroid is something which everybody sees, right? From starting from a neonatologist to a pediatrician who's looking at growth disorders, somebody who is looking mainly in terms of pubertal disorders, adolescent specialist. Thyroid disorders can present in the ICU with refractory hyponatremia. They may present as pericardial effusion to the cardiologist. They may present with large ovarian cyst to a gynecologist. So they are the differential diagnosis of pretty much a lot of conditions which we as pediatricians encounter in terms of pediatric endocrinology. And one of the unfortunate situations which we recently saw was this 22-year-old lady which really bogged us down as to why still this is happening. This was 22-year-old lady who presented with severe developmental delay, and you can see she is extremely short, had all the features of hypothyroidism, coarse skin, very high levels of TSH, clearly a case of congenital hypothyroidism with gross mental retardation presenting at this age, which really is something which we should not be having in this day and era of all the advances which happened. Similarly, we had a case of a 12-year-old boy who presented with poor school performance, and this child was evaluated for hypothyroidism, and investigation showed a low free T4 level along with a TSH level of 9. So the treating physician made a diagnosis of hypothyroidism and started thyroxine. 2 weeks later, the child presented to our emergency with shock, and at that point of time, it was realized that this child was actually having features of adrenal insufficiency. And here comes the question as to what really happened. So the point which we'll discuss in physiology in more detail is that if the free T4 level is going down in primary hypothyroidism, we expect the TSH levels to be really high. Normal or slightly elevated, maybe up to 15 to 20 milliunits per liter of TSH may actually be a suggestion of central hypothyroidism in a child whose free T4 levels are low, and we need to really evaluate for the complete hypothalamic-pituitary axis before starting treatment, because if we start thyroxine in this setting, that is expected to result in precipitation of adrenal insufficiency in this case. So in the background of these two cases, one which is a very unfortunate case which was missed, and one in which unfortunately central hypothyroidism was missed, we'll just touch base about the physiological aspects of thyroid. Now we all know that thyroid regulation largely happens as part of the three major organs, which are the hypothalamus, pituitary and the thyroid. TRH is a very small tripeptide molecule which is secreted by the hypothalamus, which acts on the pituitary on the TRH receptor to produce the thyroid stimulating hormone, which subsequently acts on the TSH receptor to produce thyroxine or T4. T4 is the predominant product of the thyroid gland, and it is this T4 which is peripherally converted by the enzyme monodeiodinase type 1 into T3 and by MDI3 into reverse T3. And thyroid is a very unique hormone in that its levels are largely dependent not only by the production by the gland but also by peripheral metabolism, because ultimately it is the T3 which is the active form of the hormone, and this T3 is produced using MDI1. So in situations like primary hypothyroidism, body would like to maintain T3 levels on the higher side. The MDI levels will increase, so therefore T3 is the last investigation to fall in a child with primary hypothyroidism, making it a useless investigation in the evaluation of either the diagnosis or treatment and follow-up of primary hypothyroidism. On the other hand, iodine deficiency is associated with activation of the monodeiodinase type 1. This has significant implications in the setting of thyrotoxicosis. So in thyrotoxicosis, if an individual is iodine deficient, one would expect T3 levels to be much higher compared to T4 because the MDI1 activity is increased. Therefore, in iodine deficient individuals, we may have a situation where T3 is high, FT4 is normal, and TSH is suppressed, and this is known as a condition called T3 toxicosis. So when we discuss about evaluation of a child with suspected thyrotoxicosis, we say that we should get both T3, FT4 and TSH, while for primary hypothyroidism, FT4 and TSH is sufficient. Now, large chunk of thyroid which is circulating is actually bound to the various binding globulins, and these binding globulins actually not only act as transport proteins, but also they act as reservoirs for the thyroid gland and they stabilize the levels. It is a very small amount which is actually available, which is circulating freely, but it is these free hormones which actually regulate the thyroid function. So conditions that affect the thyroxine binding globulin increase or decrease are associated with abnormalities in thyroid function tests, but not necessarily in actual thyroid functions. So for example, if we talk about pregnancy or the use of oral contraceptive pills which are associated with increased level of thyroxine binding globulin, we will have high levels of T4, but the free T4 and the free T3 levels will be normal, so there will be limited impact
as far as the thyroid functions are concerned, but these conditions may sometimes be referred as thyrotoxicosis because T4 levels are high. The free T3 again is a very unique compound that it actually enters the cell and it is transported into the cell by a transporter known as MCT8, and therein it acts on the intracellular thyroid receptor to cause the action. So it is very clear that a peptide hormone which has got a lot of amino acid is not expected to cross the thyroid membrane, and unless and until we have this transporter, there will be no action of T3. Conditions associated with deficiency of this transporter are associated with a unique situation in which there will be features of severe hypothyroidism from birth, but we may actually have a higher level of FT3 because there is again a no feedback inhibition in this perspective. So now in this perspective we have our first case, 12-year-old girl with tremors, and we see that her FT4 levels are 18 and TSH is 0.01. So we have suppressed thyroid, but the free thyroid hormone were normal. So at that time point, a diagnosis of subclinical thyrotoxicosis was established. Subsequent to that, no treatment was given and she presented 2 months later with further weight loss, and again the free T4 levels were normal. So what is going on here? What should be the cause or plan in this perspective? So you can use the chat option to really put in your entries as to what you're thinking of. So this clearly is a situation in which we have low TSH and normal or high normal FT4. This individual may actually be resident of an iodine deficient area in which the conversion to T4 to T3 is increased because of increased MDI1 expression. And therefore, we should have measured the T3 levels in the very beginning, and when we did that, it was found to be high. So this is a case of isolated T3 elevation, or what is known as T3 toxicosis. And this emphasizes that for every child whom we are suspecting thyrotoxicosis, please get a total T3 level along with a free T4. We'll discuss why we are talking about total T3 and not free T3, because we'll discuss this when we talk about assessment, because FT3 is not a very reliable marker in terms of thyroid function, and total T3 is a good enough test. So this highlights that total T3 assessment is essential in a child who presents with thyrotoxicosis. Another child, day 4 child who has a TSH levels of more than 100. And on this child, a diagnosis of dysharmoniogenesis was established. He was started on thyroxine, and 4 weeks later, his FT4 is on the higher side, but TSH levels are also high. So what do we do? Do we increase the dose, or do we continue the same dose, or what is the, so whether this child is actually controlled on this dose of thyroxine? So what are the options you would like to go for? Would you like to increase the dose or continue the same dose? So this clearly is a situation wherein there is a reset hypothalamic-pituitary axis because of the fetal hypothyroidism. So in this setting, the TSH levels are high and they will take time to settle down. And if we wait for a couple of months or maybe sometime up to 6 months, this TSH will stabilize. This highlights the importance of assessment of free T4 levels in the follow-up of children with congenital hypothyroidism, wherein there can be an overall problem in terms of assessment, and if you look at TSH levels in this perspective. So this is a reset HPT axis, and we need to continue on the same dose of thyroxine. So just a brief word about thyroid hormone synthesis. So we can think of thyroid gland as an iodine concentrator. So what it really does is that it gets the iodine from the blood, transfers it using the sodium iodine symporter into the thyrocyte, and from the thyrocyte it is then transferred outside the cell using the pendrin, which is again a transporter. So basically what thyroid is doing, it is that actually getting the iodine from the blood and pushing it onto the apical side, and herein the thyroid is actually organified using the thyroid peroxidase and DOX2 enzymes, and this organified iodine then combines with tyrosine to form diiodotyrosine and monoiodotyrosine, which then couple with each other to form T4 and T3. T4 is by far the most important product of the thyroid gland, and most T3, around 80% of it in the body, is actually produced by peripheral conversion. So therefore, if you want to treat an individual with hypothyroidism, T4 is good enough. There is no added advantage of using T3 in this perspective. After this T4 and T3 is formed, there is action of TSH, which causes the endocytosis of this overall thyroglobulin molecule, and from there we have the TSH, which acts on the TSH receptor to activate a lot of process. It increases the transfer of sodium iodine importer, it increases the TPO activity, it causes endocytosis and lysis of the thyroglobulin molecule, which results in release of DIT and MIT, which subsequently are converted to iodine using the dehalogenase enzyme, which causes the iodine to be reused, as well as release of T4 and T3. So the thyroid hormone pathway is largely dependent on two things. It needs iodine, so if there is iodine deficiency, there could be a lot of problems in thyroid development, and it needs TSH and TSH receptor, which becomes extremely important. Along with the release of T4 and T3, we also have a release of thyroglobulin, which gives us a very good marker of functional thyroid tissue. So when is it important to really look at thyroglobulin? If we are dealing with a child who presents to us with congenital hypothyroidism, a thyroid scan shows that there is no gland, but we want to know whether it is actually there is some functional tissue or not. We can then measure a thyroglobulin level, and if there is a detectable thyroglobulin, it will indicate that okay, the gland is there. It is probably not picked up on scan because of a problem either in the TSH receptor or in the sodium iodine importer, or a TSH receptor blocking antibody from the mother is causing the block of transfer. So therefore, thyroglobulin assessment plays an important role in differentiating true from apparent athyrosis in a child with congenital hypothyroidism. It is also of pivotal importance in following up children with differentiated thyroid carcinoma, where we have done the surgery, we have done the radioactive iodine ablation, and subsequent to that, there is basically no thyroid tissue. So if the thyroglobulin levels start to rise, it means that we are dealing with a situation where there is a residual thyroid carcinoma tissue which is coming back. So this really gives us a picture in terms of how do we go forward in terms of evaluation and follow-up. So now again we come back to this case, 10-day-old child who had a TSH level very high, so looked clearly like a permanent congenital hypothyroidism. FT4 levels were on the low normal side, not very low. Scan showed no thyroid tissue. So this child was diagnosed and counseled by the pediatrician. Okay, this is a permanent congenital hypothyroidism. The child will require thyroid hormone for life. Started on a good dose of thyroxine, and subsequently within the next 6 months, the child's TSH kept on decreasing and his dose was decreased and even stopped. And despite stopping the dose, his TSH remained stable. So what do you think went wrong in this case, who apparently had no thyroid tissue on scan, and he had a very high TSH level and seemed to have a reversible form of hypothyroidism? So what could be the possible cause? You can use the chat option to just put in what you think could be a possibility. Was the scan done wrongly, or whether we are dealing with some other transient form of congenital hypothyroidism? Sometimes DOX2 can cause situations, but that would have been expected with associated with increased uptake. So this is a classical picture of what is known as apparent athyrosis. So what we need to understand is that for thyroid scan to pick up a thyroid gland, we need to have a thyroid. We also need to have an intact TSH receptor, sodium iodine importer. So any of those problems can cause a situation where the gland is there, but we are not picking it on the radionuclide scan. This is known as apparent athyrosis, and the most common cause of apparent athyrosis in our setting, which is reversible, is the transplacental passage of TSH receptor blocking antibody. So mothers with hypothyroidism, they have the TSH receptor blocking antibody which cross the placenta, and therefore they block the TSH receptor. There is hypothyroidism which is reversible, which improves after some time, and also along with that we do see that there is no thyroid tissue in radionuclide scan. So if we have a child who presents with congenital hypothyroidism and the nuclear scan shows no uptake, it is not the end of the story. We need to look at the ultrasound, and only if the ultrasound shows no thyroid will we diagnose agenesis. In this case, ultrasound showed a eutopic thyroid, which basically means that there is a maternal hypothyroidism wherein the TSH receptor antibodies cross the placenta, block the thyroid function, resulting in the development of hypothyroidism, which was transient, at which tended to improve over time. So now we've talked about the basic physiology. But as we discussed, thyroid is very important for different hormones. So nearly every hormone is affected by thyroid. And if we do not understand this crosstalk of thyroid with other hormones, we would cause confusion in terms of evaluation and management. So in this perspective, what is important to understand that TSH has a structural homology with a large number of glycoprotein hormones like LH, FSH and HCG. Their alpha subunits are the same and beta subunits are quite similar. So if we have very high levels of TSH, they can then act on the FSH receptor and cause production of large ovarian cysts in girls. So this is a typical presentation of a girl who presents with precocious puberty, large ovarian cyst, discordant puberty, who has breast development and very soon has periods, with short stature and delayed bone age. If you have this constellation, always think of hypothyroidism. What happens in boys is very peculiar because FSH basically stimulates mainly the Sertoli cells. So we have large testes, but because Leydig cells, which are the main regulator of testosterone production, are not activated, they will have delayed puberty. So boys with uncontrolled hypothyroidism may present with delayed puberty and large testes. Girls can present with early puberty and large ovarian cysts. So this is a very important crosstalk which all of us need to be aware about thyroid hormone. Another very important part to remember is that the thyrotropin releasing hormone is the stimulating hormone for prolactin as well. So if you have uncontrolled primary hypothyroidism, wherein TSH levels are going high, TRH is going high, prolactin will also go high, and that would result in the development of hypogonadotropic hypogonadism, delayed puberty, galactorrhea, which will be reversible as soon as we correct the TSH. So hypothyroidism should always be considered in a girl who presents to us with hyperprolactinemia. We have seen cases of long-standing hypothyroidism in which the thyrotropes are stimulated so much that they cause a pituitary mass to appear, and they are falsely diagnosed as a pituitary adenoma. So this is not a pituitary adenoma, this is pituitary hyperplasia. Nevertheless, it can cause visual symptoms, it can cause headache, and it is again reversible with treatment. So we need to be very careful when we have a girl who looks like hypothyroidism, which is primary, presents with a features of raised ICT and a large thyroid, large pituitary mass. Very important from a neonatal perspective, from an intensive care perspective, dopamine and glucocorticoid inhibit TSH production, so they may result in false negative reports of hypothyroidism. So if you have a newborn who is in the NICU and who has been treated with dopamine and glucocorticoids, has presented to you initially with a normal TSH, and when you follow them up after 3 to 4 weeks, you may find that the TSH levels have gone up. So any sick child or any neonate who is exposed to these medications needs a repeat screening for TSH at least 3 weeks after birth to confirm this missed possibility of hypothyroidism because of the inhibitory effects of steroids and dopamine. HCG, as we discussed, if you see, has a structural homology with TSH. So conditions associated with increased HCG, and which is the condition which causes the maximum HCG excretion, is pregnancy. So in pregnancy, the HCG levels will be really high, and this can act on the TSH receptor to cause a thyrotoxic appearance of pregnancy. So pregnancy is a physiological thyrotoxicosis. So therefore, many pregnant women may present with features of thyrotoxicosis which are mild. There is no goiter, no eye signs. It is because of the HCG effect. It does not require treatment. Secondly, because of this high HCG, the TSH levels comes down, and therefore we need to cut off of TSH decreases by 1, and we use a TSH level more than 4 as a criteria for diagnosing hypothyroidism in pregnancy. A very important thing which leads to a lot of referral to pediatric endocrinologists is the link between obesity and thyroid. So adipocytes produce leptin, which stimulates TRH. And if you think of it, this is a physiological response. What body is trying to do is that we have got more fat. So let's use the thyroid hormone to burn that fat. So this TRH increases. After that, there is an increase in TSH, but the T4 levels don't really go up. So this is a situation which often presents with mild elevation of thyroid hormone in the setting of obesity. It is actually the effect of obesity and not the cause of obesity. Please do not treat any girl who comes to you with obesity with mildly elevated TSH levels unless the level go beyond 10. A very important association of thyroid is that thyroid increases the metabolism of cortisol. And this is what happened in case number 2, which we discussed in the beginning. So in individuals who are hypothyroid, they may have cortisol deficiency which may not manifest clinically unless and until you start the thyroxine replacement. And when you start thyroxine replacement, the cortisol is inactivated and there could be a precipitation of adrenal insufficiency in that perspective. And we need to be very careful in any individual whom we are suspecting a cortisol deficiency to exclude or treat cortisol deficiency before starting thyroxine in this situation. So we'll go through the cases now. 7-year-old girl with thelarche and menarche. What we see is that there is a discordant pattern of puberty. Height is short. So this girl is a short girl with the precocious puberty. Large ovarian cyst. Bone age is delayed. Every girl with precocious puberty should be tall and should have an advanced bone age. So what are we dealing here? She was advised surgery because there was a large ovarian cyst. So this, as we discussed, is what is known as von Wieck-Grumbach syndrome, in which there is activation of the FSH receptor by TSH causing precocious puberty along with delayed bone age. So don't miss this condition, reversible very well with just thyroid supplementation. 15-year-old girl with delayed puberty, and we see that there is no breast development, no pubic hair development. She has galactorrhea. So somebody thought there is a hyperprolactinemia. Prolactin levels were high and LH-FSH levels were low. So she was advised a neuroimaging to rule out a possibility of a pituitary adenoma. What do you think should be the most important test before we really go ahead with a neuroimaging? You can put up the options there. So this is a very important thing to rule out in this setting is hypothyroidism, because TSH here was more than 100, and because of this primary hypothyroidism, there was increased TRH production, and because of that TRH production, we had this hyperprolactinemia. So thyroid function should therefore be assessed in every child who presents with hyperprolactinemia. 12-year-old girl with obesity, as discussed, a very common finding. Height was alright, weight is high, TSH is just 6.2. Was advised to treatment even though there is no goiter. So what do you think? Do you agree with this? Treatment should be given or not given in this situation? I think it's very important to understand that this is the effect of obesity because of the effect on TRH. It is not the cause of obesity. This is compensatory, reversible. No treatment is required unless the TSH levels are more than 10. There is a goiter, there is a TPO positivity, and that will be the only situation in which we like to treat. In this perspective, we should measure the free T4 levels which were normal in this situation. 4-week-old boy who now presented to us with complaints of prolonged hyperbilirubinemia and was found to have hypothyroidism. So you made a diagnosis that this is hypothyroid, but parents are really angry because this child actually underwent a neonatal screening, and a neonatal screening was told that there is no hypothyroidism. So what is the possible cause of this apparently normal neonatal screening now presenting at 4 weeks of life with hypothyroidism? So if you go back to the history, this child was born SGA, had an eventful perinatal period, had required vasopressors and antibiotics, and there lies the clear-cut story that these vasopressors, particularly dopamine, stress, and all those situations will result in a non-thyroidal illness, and this was the real cause of causing a false negative report on neonatal screening, and this emphasizes the need of a repeat screening after 3 weeks period at least to evaluate for a follow-up of hypothyroidism. Now we talk about another situation, 26-year-old female presenting with pregnancy and tremors. and we find that she has tremors, tachycardia, features of thyrotoxicosis. FT4 levels are not very high, TSH is slightly low, so there is no thyromegaly, there is no eye sign. So what is the possible cause of this constellation of findings? Clearly, first thing which we have to think of is the possibility of Graves' disease, because Graves' disease is common, is important, it has significant implications for the child as well. But if you look here, there is no thyromegaly, there are no eye signs, FT4 levels are slightly elevated. So the first possibility clinically we have to think of is that of a HCG induced thyrotoxicosis, which is gestational thyrotoxicosis, which is self-limiting and improve. So in this case, clearly we will not do a thyroid scan, we will not do an ultrasound, we will not at all start the treatment. We will observe and follow up in this perspective. So mild thyrotoxicosis in a pregnant woman should always consider the possibility of gestational thyrotoxicosis. Now we have a 12-year-old boy. This was the case which we discussed, who presented with poor school performance, FT4 low and TSH inappropriately low. Any TSH which is less than 20 with a low FT4, always treated with a pinch of salt, with a caution. Think of central hypothyroidism, which was missed in this case, which resulted in the development of shock. So very important to exclude central hypothyroidism in individuals who have mildly elevated TSH or normal TSH in the setting of low FT4 levels. So now we've talked about the thyroid synthesis, we talked a bit about its metabolism. Now we talk about the transport. So the thyroid hormone in the body is transported bound to the binding globulins. Most important one is the thyroxine binding globulin. We also have the albumin and the prealbumin, which also play an important role. T4 is more bound, it is largely bound to TBG, while T3 is bound to all. So alteration in any of these levels will cause alteration in thyroid functions, and particularly in thyroid function tests, and we can have normal thyroid functions also in that perspective. So most important confounding factor in this setting is estrogen, which causes increase in TBG, particularly in the setting of pregnancy, oral contraceptives, or use of selective estrogen receptor modulators, resulting in a constellation of high T4, normal free T4, and normal TSH. This condition does not require treatment. We can have things like testosterone and glucocorticoid, which will actually decrease the TBG levels, and therefore we will have a situation of low T4, normal FT4, and TSH levels. So situations wherein we have a discrepant T4 and TSH levels, we should always think of doing a free T4 level. That is a big message which comes out of the setting. Hypoalbuminemia in the setting of nephrotic syndrome and chronic liver disease can again result in the situation. Heparin and use of NSAIDs can cause decreased binding of T4 to TBG, and this causes transient elevation in free T hormone levels, which needs to be just followed up in that perspective. So now we have a 10-year-old girl with poor concentration. Height is 136, weight is 34, clinically euthyroid. TSH levels were normal, but T4 levels were reported as low. So would you think of central hypothyroidism in this case, or would you like to do something else before doing extensive evaluation? So what really is the plan? So as discussed, central hypothyroidism is important, but it is quite rare. And in fact, TBG deficiency may be more common in certain settings than central hypothyroidism. So it's very important to actually assess the free T4 levels before doing any further evaluation. And what we found in this perspective, the TSH is normal in fact. So FT4 was found to be normal. So this is again no need of treatment, and this is classically a case of low TBG level resulting in falsely low levels of T4, no treatment required. 17-year-old girl with hyperandrogenism, and again this is a very common situation. Somebody with polycystic ovarian syndrome, we always do thyroid functions, and what we found here, she had menstrual irregularity, she was clinically euthyroid, her TSH levels were slightly elevated, but T4 levels were high. So a label of thyrotoxicosis was made. Do you agree with that? I think you can put your options in the chat. So what we clearly see out here is that T4 levels are elevated and TSH are also elevated. any individual who has a high T4 should have an undetectable TSH if we are talking about thyrotoxicosis from the thyroid gland, which is the most important cause in children. So clearly we need to confirm the actual presence of thyrotoxicosis by doing a free T4 levels, which in this case were clearly found to be normal, and they basically excluded the possibility of a thyrotoxicosis. This child was actually on oral contraceptive, which would have increased the TBG level and resulted in elevation of thyroid hormone levels. So very important to look at the clinical context that we are dealing with, because that will have clear-cut implications in terms of evaluation and management. So this was high TBG levels, which resulted in false diagnosis of elevated T4 levels. Now, as we discussed, that thyroid metabolism plays a very important role in the overall functioning of thyroid, in that the T4 is converted by the monodeiodinase type 1 in the target tissues, particularly the liver, kidney and thyroid, to in the systemic and the target tissue to T3. So it activates thyroid hormone, which is then sulfated into the inactive from T3 sulfate. We have another monodeiodinase type 3 which causes inactivation of thyroid into reverse T3, and this happens particularly in placenta and fetus. So the role there is the fetus wants to really be in a dormant state, doesn't want a hypermetabolic state, so we have more expression of MDI3. There is another very important conversion enzyme which happens to be MDI2, which converts T4 to T3, but this largely is there in the key areas of brain, pituitary and the brown adipose tissue. So in situations where there is less amount of thyroid, this MDI2 will be activated and you will spare the brain activity. Understanding this whole mix of thyroid metabolism is very important because it has got clinical implications in this perspective. In iodine deficiency, there is an increased expression of MDI1, resulting in a higher level of T3, resulting in the diagnosis of T3 toxicosis, as we discussed in a previous case. So what happens in fetus? The fetus in a state where it wants to avoid thermogenesis, it therefore has low levels of T3 because MDI1 is less. There is increased sulfation, so T3 whatever it is, it's bound to T3 sulfate, so there is no hypercatabolism. It is in an anabolic state and therefore we have more MDI3, so all thyroid is inactivated. It also wants the preservation of brain function, so therefore MDI2 is upregulated, resulting in sparing of brain effect. So fetus typically is therefore associated with a low T4 state with a TSH level which may be normal. So if we have a premature infant, it is a physiological response to have a low T4 level, and this does not require treatment. This has significant implications because actual treatment of preterm infants with hypothyroxemia of prematurity may result in adverse effects rather than benefits. So they don't need treatment, just follow up and observation is important. Very, very important thing to understand is the maternal fetal transfer and how this whole regulation plays an important role in that. We need to understand that placenta acts like a very active sieve of a lot of hormones, and in particular the TRH is the only hormone which easily passes because it's a small molecule, it's just a 3-peptide hormone. TSH clearly cannot cross the placenta, and this is very important. Otherwise, any mother who has hypothyroidism will have thyrotoxicosis in the child. So TSH cannot cross the placenta. T4 and T3 are inactivated by the placental monodeiodinase type 3, but they do cross. So 40% of T4 levels in the fetus may be observed even in athyrosis because of this maternal transfer of T4, and this is very important because fetus lives in a relative thyroid deficient state. So even if we get that 40% from the mother and it is not producing any thyroid hormone, it would be able to really cope with it, and therefore if we start treatment before 14 days of life in congenital hypothyroidism, the child will do fine in that perspective. So this is very important to understand in that perspective. The big question which comes to our mind here is that what will happen if the mother is hypothyroid in terms of intellectual outcome of the fetus, and this is a big question which comes with pregnant women. There are a number of studies which have shown that timely treatment of even severe primary hypothyroidism in the first trimester is associated with normal intellectual outcome in the fetus. So even if you have a mother who comes with TSH of more than 100 at the first screening visit, 6 to 8 weeks of life, don't worry. The only adverse effect at that point of time may be miscarriage. It won't have any fetal effects if you start treatment at the right dose, which is high compared to other individuals, and maintain a normal thyroid functions. You will have a good outcome, and this is an important point to counsel in this perspective. On the other side, the thyroid receptor antibodies, whether blocking or stimulating, cross the placenta. They have a half-life of around 2 to 3 weeks. So if there is more blocking antibodies, they will cause hypothyroidism, which will result in apparent athyrosis, which improves over around 2 to 3 months. If there are stimulatory antibodies, there will be thyrotoxicosis, which would again be a transient phenomenon, typically resolving in 2 to 3 months. Complicating this picture is that methimazole, the anti-thyroid drug, can also cross the placenta with a half-life of 2 days. So if there is a mother who has Graves' disease, is on an anti-thyroid drug, there is a passage of both thyroid stimulating antibodies and methimazole, and this can complicate the picture. So in the initial phase, the child may present with hypothyroidism, which may then progress to thyrotoxicosis, because as methimazole wanes off, the thyroid levels will go up, and when thyroid receptor antibodies goes off, the thyroid receptors become normal. So now we have a 28-year-old lady with pregnancy 6 weeks, and on routine screening she was found to have a TSH more than 100. She comes to you for counseling whether she should continue the pregnancy or not. So what do you think? We can just have the chat options again in this perspective. She was TPO positive, so definitely she requires treatment, but there is a role of high dose thyroxine but not termination, because we expect good intellectual outcome if we start treatment at this time point. Unfortunately, in many situations they are counseled against that, and they may not conceive again because of hypothyroidism. So it's very important to carry forward pregnancy and give a message that if we treat at the right time, maintain thyroid functions normally, they will have a good outcome as far as the newborn development is concerned. So now we have a day 4-old child of infant born to a Graves mother who was on methimazole 20 milligrams. Now the child presents at day 4 with low free T4 and a high TSH. So this is hypothyroidism. So we did nothing, we just observed. At day 14 of life, the FT4 levels became 42, which were very high, and TSH levels became undetectable. So what do you think went wrong? So this is what we were discussing of the impact of transfer of TSH receptor antibodies along with antithyroid drug. So this was a typical situation. Then first time we had methimazole effect causing hypothyroidism, which improved over a couple of weeks, and then we have this stimulating antibody which is causing thyrotoxicosis, which will also improve over time. What happens postnatally? I think this is very important. As soon as the child is born, it is faced with a lot of challenges, and this we are going to cover a lot on perinatal endocrinology when we discuss on that module. There are most important change from a thyroid perspective is that the child comes from a warm intrauterine environment to a cold stress situation and requires to burn a lot of fat to produce energy. So we need thermogenesis to happen, and for this to happen, the MDI1 starts to get activated, and there is increased T3 to converts into a catabolic state. The reverse T3 formation is decreased, and therefore this is what happens is we have a thyroid surge, and this surge results in high levels of T4, T3 and TSH in infants for the first few weeks of life, particularly for the first week of life. So if you want to do a thyroid function assessment in a newborn, particularly if you're looking at TSH levels, we should do it after at least 48 to 72 hours of life. If that is not feasible, we can do a cord blood values, but remember we have to use specific cutoffs from that perspective. So we have this 20-year-old girl who presented with a TSH of 36. What is the plan? So in this case, clearly what we see is the TSH level was done a bit too early, and this 36 may not be significant, so better is to repeat, and when we repeat it after a couple of days, it was found to be normal. So again, the message is please do not do thyroid functions in the first day of life. There are recommendations which suggest that after 24 hours of life, a cutoff of 34 international units can be considered as something which requires further assessment, but definitely not in the first 24 hours of life. So how does thyroid hormone act? And we discussed about that T4 is converted into by MDI1 to T3 or MDI2 also in the target tissues, which is then transferred in the cell using MCT8, which then binds to the thyroid response element, causing action of the RXR, causing gene expression and producing thyroid action. So there is a very unique condition which we're discussing now, a 2-year-old girl with severe developmental delay, low levels of T4, normal level of TSH, high levels of T3, along with extrapyramidal symptoms. So this is an unusual situation. This child looked like hypothyroidism but had high T3 level. So what went wrong out here is that there was a transporter defect. So no T3 could go inside the cell and therefore T3 is high, but the child is somewhere like drowning in the sea. They can't drink the water because it's salty. So same, there's a lot of T3 in the circulation, but it is not getting into the cells to act, and therefore this is a rare but an important situation to understand in this perspective. So in terms of pathophysiology, hypothyroidism could be caused most commonly because of a problem in the thyroid gland, which is known as primary hypothyroidism, associated with high levels of TSH. It mostly occurs in the setting of autoimmune disorders, insult, infiltration, radiation, or iodine deficiency. In congenital hypothyroidism, it is largely because of dysgenesis, while autoimmunity is the most important cause. Very important to think of other autoimmune conditions like celiac disease or diabetes or even adrenal insufficiency in appropriate setting. We can also have a central problem in which the problem is in the setting of TRH receptor or TSH or hypothalamus or pituitary. This is usually associated with combined pituitary hormone deficiency along with low, normal, or even up to 20 TSH as we discussed. It is usually associated with hypopituitarism, rarely with other disorders. We can also have problems in transport or resistance because of thyroid receptor resistance, very, very rare problem. And we can also have a large hemangioma which consumes all the thyroid hormone, which is known as consumptive form of hypothyroidism. So from a clinical perspective, we are mainly talking about primary hypothyroidism, and always keep your eyes and ear open about central hypothyroidism as well. Thyrotoxicosis, on the other hand, can also be TSH independent, in that we have undetectable levels of TSH, which may occur because of a TSH receptor stimulating antibodies in the setting of Graves' disease or thyroiditis, where there is a damage to the thyroid gland. We can also have an independent nodule which can produce, or a multinodular goiter which will cause a similar picture. This is often associated with increased thyroid receptor antibodies or a TSH receptor stimulation, which may happen rarely in the newborn period. Very, very rarely we can have a TSH dependent thyrotoxicosis, very uncommon in children, where you have detectable TSH. So detectable TSH with a high FT4, always think of a central cause and a possibility of TSH adenoma, very rare in children. Again, resistance can cause similar picture, very rare. So thyrotoxicosis, the main differential is whether it is increased production because of TSH receptor stimulating antibodies, where we need to give antithyroid drugs, or it is destruction of the thyroid gland in the setting of thyroiditis, wherein there is a release of thyroid hormone which will improve over time. No need of antithyroid drugs, we just need to follow them up with thyroid functions. Very importantly, for those who are dealing with intensive care patients and those who deal with neonates, there is always the possibility of a non-thyroidal illness, wherein there is an increased action of MDI3, which causes increased reverse T3, and decreased action of MDI1, which causes decreased T3. This situation, because body wants the brain to compensate, the MDI2 activity is increased, and therefore the T3 levels at the brain are high, and therefore TSH levels may come down. So non-thyroidal illness in the acute phase will be associated with low levels of TSH, T4, and low T3 and FT3. You will be high RT3, but that is not usually tested in most labs. Once the recovery happens, this MDI3 activity is decreased and there is increased MDI1, which results in increased level of T3, and subsequently the TSH levels tend to high. So on recovery, they may present with high levels of TSH, low T4, and make a false diagnosis of a primary hypothyroidism. So please don't do thyroid function tests unless absolutely essential in an admitted child. If you do, always be aware that during illness they may look more like central hypothyroidism, while on recovery they may look like a primary hypothyroidism, but they usually improve over time in most perspective. So they should ideally be followed up after 3 weeks. So 10-year-old boy with pneumonia, FT3 level is low, FT4 levels are low, TSH levels are also low. So what is the plan in this situation? He was advised treatment, but definitely this is a wrong approach because this is a non-thyroidal illness. There is no need of treatment. Repeat after 3 weeks. FT4 levels were then found to be slightly normal and TSH went up. So this is again a resolving phase of non-thyroidal illness. Very important to follow it up in this and not start treatment. What about prematurity? And this we discussed earlier, that prematurity is basically a replication of what is happening in the fetus. The fetus is in a relative hypothyroid state. So in prematurity, again, the MDI2 is active, MDI3 is active. So therefore, we have more reverse T3 and we have low T3 and T4. So low TSH, low T4, low T3, low FT3 is common in prematurity. If we treat that, and it has been shown in randomized controlled trial that it may worsen the outcome, not improve. So please do not treat a child who has hypothyroxanemia of prematurity because that can have more harm. Because of that, they should be retested at discharge. It's a physiological state. If TSH is persistently above 10, one may consider treatment because this could be a primary hypothyroidism which may be missed in that setting. 26-week-old boy, day 10, a routine test was done. FT4 was low, TSH was normal. So definitely this is a classical transient hypothyroxanemia of newborn. No need of treatment. In this perspective, this will resolve over time. Repeat thyroid function after 3 weeks were found to be normal. So now we have talked about the overall thyroid physiology. We have talked about the causes. What about the effects? So thyroid hormone affects every part of the body, which includes the bone, the brain, the heart, the thermogenesis, growth plate, and motility. So hypothyroidism can present to us with developmental delay, cardiomyopathy, bradycardia, hypothermia, epiphyseal dysgenesis, constipation, while thyrotoxicosis will present with osteoporosis, abnormal behavior, even attention deficit disorders, cardiac failure and tachycardia, hyperthermia, advanced bone age, and hyperdefecation. So we need to be aware about these varied conditions wherein we can have the problems in this perspective. So once we have done that, we'll now move forward quickly to the key aspects of clinical assessment of thyroid function. We'll talk mainly about clinical as well as the thyroid function test. How do we interpret that? The thyroid assessment will focus on clinical as well as the functional aspect of it. So thyroid examination is very important. So start off with inspection. Look for movement with deglutition and protrusion of tongue. Sometimes there may be some other midline swelling which may not be thyroid, so they will not move with deglutition, and this will help you. Sometimes we find even a tubercular lymph node presenting at the situation diagnosed as goiter mistakenly. Always palpate from backside. Look for the swelling, size, surface, and consistency. If you have a hypothyroid child with a firm bossulated goiter, this is thyroiditis. If it's a very soft, rubbery goiter, this is dysharmoniogenesis. If you have thyrotoxicosis, you have a firm goiter, this is Graves' disease. If you have thyrotoxicosis with irregular bumps in margin, this is toxic multinodular goiter, or sometimes you may actually have a single nodule also. All of them can be picked up on examination. Always look for percussion to look for a retrosternal extension, and auscultate particularly for bruit for Graves' disease. What about newborns? And in newborns, identifying goiter will really help you. If a newborn has congenital hypothyroidism and you can feel a goiter, it excludes dysgenesis. So what you do is that ask the child on the lap of mother, extend the neck, and then try to feel for all the laryngeal cartridges. If you are able to feel for the cartridge, it means that there is no thyroid at all. But if you can feel a resistance, then you can document the presence of thyroid or a goiter. So having discussed all that, we'll now focus for the next 10 minutes or 5 to 10 minutes about thyroid functions because they are a very important aspect of this, and then we'll close and start off with discussion. So thyroid function tests are done very routinely, usually as a screening test. Most often the tests are negative and they may represent a physiological variance. So we need to be really having a test which needs to be robust to detect all that. Very importantly, thyroid hormones are high as far as basal levels are concerned. There is a limited role of dynamic tests, and there is no clinical effect as far as timing of the thyroid function test, because often people will say when to do the test. So in this perspective, we need to understand the relationship between the three hormones. So in hypothyroidism, we would expect, if it is primary hypothyroidism, the TSH should go up, the T4 should go down, T3 will go down very late. So in primary hypothyroidism, T3 is a useless investigation, so to speak, while T4 will be more important. So this is in hypothyroidism. T4 and TSH should be considered. What about thyrotoxicosis? Here in TSH should become undetectable, T4 levels should increase, and T3 may in fact increase more, particularly if we are iodine deficient because of the increased action of MDI1. So this is a situation in which we should do a T3, T4 and TSH. So the role of T3 basically is now relegated only for suspected thyrotoxicosis in terms of diagnosis and follow-up. The relationship between TSH and T4 is very interesting. It is basically a log linear relationship. What it means is that mild changes in FT4 will result in dramatic changes in TSH levels. So if the FT4 goes down, TSH should really be high, which is basically primary hypothyroidism. If we have a TSH which is low, normal, or even up to 15 to 20, this means that there is central hypothyroidism. On the other hand, if the FT4 is high, this means it is thyrotoxicosis. We expect the TSH to be undetectable, which is thyrotoxicosis. But if TSH is detectable, not even high, we have to think of a possibility of a TSH secreting adenoma, which is extremely rare. So this gives us a very important overview as to how to interpret thyroid functions. So TSH is the most important test. It should be done. There is a huge diurnal variation of 40%. There is a 50% interday variation. The highest levels of TSH are at night time. But because the range is so wide, we can do it any time of the day. So range is 0.4 to 4 with higher level up to 6 in children up to 13 years of age. Limitation of TSH is that there are fluctuations. As we see with different ages, there are so many variations which happen, and therefore we have to act according to levels. So for neonatal TSH on screening, if the levels are more than 40, we need to evaluate and treat. If the levels are less than 20, nothing is to be done. Or if somebody is doing in day 234, as far as the ISPA recommendation are concerned, should be considered the threshold for action. If the levels are between 20 to 40, in this perspective, we should repeat after 2 weeks. If after 2 weeks the levels are more than 20, treatment is required. If it's between 6 to 20, again we have to think of the cause and treat. While if it's less than 6, in that situation, no treatment is required. So age appropriate TSH cutoffs are absolutely essential. What about childhood? In childhood, if the levels are more than 10, we have to think of treatment. If the TSH levels are less than 6, this is in normal range. If it's 6 to 10, it is subclinical hypothyroidism. Action will depend upon whether the FT4 levels are low or not. If FT4 is low, we have to rule out central hypothyroidism and start treatment. But in most cases, FT4 will be normal. So we reassure them. And if the FT4 is normal, look for risk factors like TPO positivity, goiter, growth failure. If they are present, then nothing is to be done. If they are absent, nothing is to be done. If they are present, we need to treat. So basically, a cutoff of 6 and 10 should be remembered in the childhood, while in congenital hypothyroidism, we talked about levels of 6, 20, and 40. What about total T4 and T3? These hormones depend on the timing because they have a short half-life, so they should ideally be done in the morning before the drug is taken. They suggest the severity of the disease. They are limited by TBG dependence, and in particular T3 is affected by MDI. So in hypothyroidism, T3 will be the last investigation to go up, and that makes it less important in primary hypothyroidism. Alterations in thyroid binding can cause problems, so it can increase with the use of estrogens and OCs, particularly in neonates and some of the other drugs. It may decrease with hypoalbuminemia, use of androgens. So we need to consider all this when we are assessing the thyroid function in this situation. Sorry, so if you have increased level of binding globulin, you will have high T4, normal FT4 and TSH. If you have decreased level, you will have low T4 with normal FT4. And if there is a binding problem, particularly with the use of heparin and NSAIDs, you can have high FT4, which is transient. That makes it the assessment of free T4 very important. The advantage being it is independent of TBG. The assay ideally should be an equilibrium dialysis or ultrafiltrate, but most labs do not do it. Most labs do an indirect measurement of FT4, which is unreliable in pregnancy and illness. So if you have an outpatient child, you want to evaluate FT4 TSH is good. But in a sick child, this FT4 may not be as reliable because, as we discussed, that illness inhibits the binding of F-thyroid. So then there can be a problem in terms of assessment. We can have a falsely low levels in those situations. So finally, coming on to the overall interpretation of the thyroid function test, which is the crux of the whole talk, best is to do TSH and FT4. If TSH is low and we have low FT3 and low FT4, we are dealing with central hypothyroidism. FT3 may also be normal. So normal FT4 and low or even normal TSH, think of central hypothyroidism. We have a very rare situation in which FT3 is high, FT4 is low and TSH is low. This is T3 treatment. This is very, very rare. We can have a situation in which TSH is low and FT4 is high. FT3 is also high. This is classical thyrotoxicosis. While we may have a normal FT4, high FT3 and low TSH, which makes it T3 toxicosis. If the TSH is normal with a high FT4, very, very rare situation of thyroid hormone resistance or TSH adenoma. While if the FT4 is low and TSH is normal, think of central hypothyroidism. Finally, if the TSH is high and FT4 is normal, this is subclinical hypothyroidism, and FT4 is low, it is overt hypothyroidism. So this has been a great experience and hope we'll be more interactive subsequently with more options like polling, which will be available from the next time. Thank you.